Philadelphia International Medicine, PIM, provides international patients and physicians with access to an unmatched network of world-renowned doctors, surgeons, and hospitals that deliver personalized medical, surgical, and rehabilitative care ranked among the best in the world. Since 1999, Philadelphia International Medicine has helped patients and physicians from around the globe eliminate the guesswork, planning, and anxiety of finding and connecting with doctors and hospitals ranked among the best in the world. With 8 hospitals, 2 medical schools, 2 cancer centers, and hundreds of top doctors, only PIM can bring you into its medical family with one easy phone call or email. Thanks for joining our presentation. Philadelphia International Medicine's Global Education Media Program is a monthly digital platform that invites physicians from around the world to exchange knowledge and innovative uses of medical technology, review the latest advancements in research and clinical care, and share best practices in case reviews. To contact our presenter, refer a patient, or more information, email physicians@philadelphiamedicine.com. Follow PIM's YouTube channel for more educational videos.
All right, good morning. So my name is Alex, I'm a surgeon here at Vincera Institute, and I'd really like to thank you all for either staying with us late in the day or joining us this morning. Really excited about the opportunity to speak with you about what's really become an emerging field, and it's really the center of our universe in terms of talking about this stuff. So I'm really excited to hopefully engage in some sort of discussion here. Feel free to stop and ask questions at any time. I'll do my best to see if you're chatting and chime in. Just interrupt me if anything warrants a question. And also I'll pause at the end of a portion to let you guys comment and ask questions as well. But please feel free to stop me at any time. So like I said, I'm a surgeon here at Vincera, and I'm on faculty at Jefferson and Drexel, which are university hospitals in town. But really Vincera is a collaborative between a lot of the large university systems here on the East Coast in Philadelphia and New York. And what I'd like to do is just kind of go through the concept of core medicine today, and really just hopefully have you come away with 3 key points. One is just really an understanding of the anatomy and the concept of the core, which on its surface may not sound like something all that interesting, but really when we get down into it, it really does kind of challenge the way we think about this part of the body, and really is a new concept and a new way of thinking about this stuff for many people, and is really important when it comes to treating pain and injuries in this part of the body. And that's really the crux of why core medicine is so important to me. It's really, really, really key in terms of figuring out a lot of, seemingly mysterious sources of pain. And then also I'd like to take a couple minutes and just talk about who we are here at Vincera and tell you a little bit about ourselves. And the final portion of the talk is just I have a series of cases that really I could go on all day taking you guys through and hopefully discussing with you. And so my goal is to get through some of the basic anatomy and pathophysiology stuff in the cases. So hopefully this will be interesting for you guys. So very, very quickly, this is a little bit of a gruesome picture, but just to kind of give you a concept of what the core is. We really think about the core as the most important part of the body. It really is from the chest down to the mid-thigh, and it's really the foundation from which we're able to move our arms and our legs. And it contains the power muscles that move us through the world, and it also contains the harness which keeps our upper body attached to our butt and legs when we're moving. And certainly we think about the core as really the center of all this activity. And when you have an injury in the central area, it really puts the periphery at risk. Just like the concept of the ACL, when you have central instability, you then can develop subsequent damage. And really the same concept is true when we're talking about the core. So when we talk about the core, we really break it down into 4 parts. Again, chest to mid-thigh. And this is a body worlds exhibit that we're using just to kind of demonstrate here. Basically the 4 parts include the back, the ball and socket hip joint, and for the purposes of this definition, we're really just talking about the bones within the hip joint itself, the ball and socket, excluding all the other structures that we know are present. And then you've got basically the skeletal muscle that's present from the chest to mid-thigh, and then the final group is everything else. And really, just to briefly go through these four groups, the back includes the vertebral column. There's, the large erector spinae muscles, and then all the nerves that kind of exit the spine, and also the ribs play an incredible structural component within the way this part of your body is able to move and flex. And really, if you think about the rings of the rib and then the vertebral column itself, it's really like a slinky. And that's how you can think about, from a biomechanics standpoint, how the back functions within the core. When you talk about the hip joint, there's obviously a lot that's kind of underway in terms of research and treatments for hip injuries. And certainly we're involved in a lot of that stuff. And I don't talk a lot in this talk about the hip pathology and treatment itself. I'm more focused on the next part of the core, which is the musculature. And that's really all the skeletal muscle from the chest to the mid-thigh, and just an incredibly rich area to discuss and talk about the injuries that can take place there. And then the final group is everything else. And that's really an interesting one, just because you can imagine all the organs and physiologic systems that are present within this part of the body. And many of them do cause pain, kind of mysterious growing pain. And so you got your gastrointestinal, your nervous, your vascular systems, reproductive organs, and all these things need to be considered when you're talking about looking for the source of pain in this part of the body. So the first thing I just like to talk about when I'm speaking about the core is just to kind of go back to medical school. And, in my experience, we learned a lot about the anterior abdominal wall and the musculature and the, obviously, pelvic structures. But one thing that was always kind of, not highlighted at all was really the pubic bone itself. And that's really become the center of my universe. And this is just a great example. This is from one of my medical textbooks. And you can just see down here, I don't know if my arrow projects, but there's a big green arrow pointing to the pubic bone and its attachments. And they didn't even, put it in the field. It's not even warrants taking the skin off to show you where it is. And I think part of that is just because the way it's described is basically not exactly how it actually does when you look at it in a cadaveric dissection. Many, the Netter diagrams and other diagrams show the abdominal musculature attaching to the top of the pubic bone, and that's actually not the case. When you look at these muscles, the rectus abdominis actually is stretched out over the top of the pubic bone and attaches to the anterior aspect of the pubic bone, and that's what we're trying to convey to you here in this cadaveric dissection. You see the muscle fibers coming down, and then there's a sheen of white where that muscle is attaching to the anterior aspect of the pubic bone. And similarly, you've got adductors that come up from below, from the medial thigh, and they attach basically to the same area on the front of the pubic bone. And that's just incredibly important when you're talking about, the most common muscular injuries that we see in the core, and the, very common cause of groin pain is actually centered at the pubic bone in these muscular attachments. And so functionally what you have is a group of four muscles on each side: the rectus abdominis, the adductor longus, pectineus, and adductor brevis, all having a common attachment at the pubic bone on the anterior aspect of the pubic bone. And here we just see another view. This patient had a pyramidalis muscle as well, which we don't think factors too prominently into the actual biomechanics of the function of these muscles in this construct, but certainly is present there. And then also, when we reflect the adductor longus and pectineus, you can see the adductor brevis deep to that as well. And what you get from these four muscles is basically a harness. So the rectus abdominis starts at your rib cage, costal margin and lower ribs, spreads down across the anterior aspect of your abdomen, and then inserts on the pubic bone. From there, the harness then goes down to your medial thighs. And this is what allows all the power derived from your back and your butt muscles to actually be translated into functional movements. Anytime you move athletically, that's putting tremendous forces on this harness. And principally the weak point is those pubic bone attachments. So we really focus in on that. And the way the muscles attach to the pubic bone is somewhat unique in terms of when we're talking about muscular attachments. And I think this is a source of a lot of confusion. The way to think about it, this is an oversimplification, but the way to think about it is basically the pubic bone is a baseball. And I actually, in my office, I don't have this. This is not a plant, but when I was thinking about this a lot, I had a baseball. And basically, the way to think about it is the pubic bone itself is the center of the baseball. And yeah, you can see that. And then basically there's this really thick fiber cartilage on top of the baseball, and that's what's kind of highlighted in green here. And what you have is actually the muscle fibers investing directly into that cover of the baseball. And there's really not much of a tendon in terms of these attachments. And we do talk about adductor tendons, and people will talk about aponeurotic sheets of the rectus abdominis, and that's all, you know, from an anatomic standpoint, that's not inaccurate, but certainly conceptually it makes a lot more sense. You understand these pathophysiology, these injuries better if you just think about the actual muscle fibers investing into this really thick tissue. And actually, to prove it to you, what you see here, this is actually skeletal muscle in section here. And you can see that there's just these interdigitations where the muscles really just invested into the fiber cartilage itself. And that's really significant when you're talking about these injuries. And this is just a diagram trying to show you again that same interdigitation, or you know, that meeting point of the skeletal muscle and where it kind of blends in with the fiber cartilage of the pubic plate. And this is another section just trying to show you generally what's going on there. And so when you look at these this attachment in the cadaveric dissection, there's really not a real tendon. What looks like a tendon from the outside, if you simply divide a very thin layer of fibrous tissue, there's actual muscle fibers deep to that. And that's very significant when you're talking about this. So it looks like a tendon, especially on ultrasound. But if you get in there in dissection or surgically, you can see that there's actual muscle fibers deep to that portion, and that's significant. And so basically there's just, like I said, there's tremendous forces being applied on this part of the body with any athletic movement, and also at rest, and that's significant as well. And what tends to happen is your slight rectus abdominis strain or adductor strain, and we've all had groin pulls over the years, this tends to be a cumulative effect, and it's acute on chronic in terms of the injuries that develop that tend to result in groin pain. And eventually, when you've damaged enough of the muscles that attach to the pubic bone, you get an imbalance from the pulling from above, the rectus abdominis as denoted here by these large arrows, and pulling from below, which principally is the adductor longus, this long arrow here, and pectineus, which is this kind of other large arrow. And this is, you know, the size of the arrow is meant to reflect the kind of force vectors, the magnitude and direction of the forces. And basically, when there's an imbalance between these forces, the muscle fibers are pulling loose from that fiber cartilage pubic bone, but in addition, that actual fiber cartilage works its way loose from the bone, just like this baseball I was holding. The actual thick tissue on top of the bone works loose and fluid seeps in, and that causes pain right at the pubic bone. Typically, if you rest, you can decrease the forces applied and it tends to feel better. But then when you apply those forces again by trying to do something athletic, the pain recurs. And that's just the classic kind of core muscle injury, the classic quote-unquote sports hernia. And certainly there's no hernia involved in this type of injury, and so we really are just trying to kill that term. But that's really the classic injury that we deal with, you know, every day here. And certainly it gets more complicated from there, but that's really the basic concepts that I'd like you guys to come away with. And, you know, my mentor and the founder of Vincera is William Myers, and he really got into this as a hobby. He was a very busy liver surgeon at Duke in North Carolina at the time, and having been a fairly successful collegiate athlete at Harvard, and being a tall guy hanging out with the basketball coach and a lot of the other athletics department folks, everyone kind of assumed he was a sports med orthopedic surgeon, so came up to him asking questions. And one of the questions he got a lot that he just didn't know the answer to was, I have this groin pain, or my son has this groin pain, and he just can't play. And basically he got curious about it. He'd seen it enough times to start to wonder, so he went to the lab and really just started looking at the anatomy, and that's when he realized that the anatomy of the pubic bone was totally different than the way he'd been taught. And he got into just kind of playing around with the force vectors, like that diagram I was just showing you. And so this is a nice picture. He actually had his medical student place her finger underneath the adductor longus muscle, and he was saying, just tell me if you can feel a difference when I cut this rectus abdominis muscle. So he started cutting a small portion of the rectus abdominis muscle, and rather violently, the whole pelvis tilted downwards, which basically slammed the pubic bone down on her finger. And, it really hurt her. And I think the level of excitement that everyone else in the room had was probably disproportionate to how much pain she was in. There was apologies all around, I'm sure. But basically, this was a really important study because this was a cadaver. There was really no forces being applied. And then when you go there, it's enough to, cause pretty violent shifts. So you realize there was tremendous force involved. And that really kind of started this whole, what is really a new field in medicine to understand these injuries. And again, so it's that imbalance between the muscles from above and below that creates the wiggle, and that fibrocartilage plate gets dislodged from the bone. And once that happens, that really doesn't get repaired. And you can rest and it'll feel better. But again, when you get back into applying really extreme forces to this part of your body, that plate just wiggles loose again, fluid comes back, and the pain recurs. And so, one of the next important steps that took place, over a decade later, was actually being able to demonstrate these injuries on any type of imaging. And so he worked really closely with one of the radiologists at Jefferson in Philadelphia, Adam Zoga, and he basically got interested because Dr. Myers was treating a lot of, prominent athletes with groin pain, and they were doing well, and he wanted to help figure out what was actually going on radiographically. And so he started doing some MRI experiments looking at cadavers. So Dr. Myers would show him what the injury looked like surgically, show him what it looked like in a dissection, and then he would go take that cadaver and put it through the scanner. And he was actually able to play with a gynecologic coil and kind of turn it 90 degrees, which is, kind of silly sounding, actually. And then he was able to show the pubic bone. So he changed the angle from a normal pelvic MRI and really kind of follows the slope of the pubic bone. And then all of a sudden you're able to see these pubic bone attachments. And this is something that, he published 10 years ago. And still it's something that creates a lot of confusion, because if you do a regular pelvic MRI, you just don't see any clarity of these muscular attachments and that fibrocartilage cover the pubic bone. What you tend to see is just kind of a hazy white in this area. And so oftentimes people are diagnosed with stress fractures. That concept of osteitis pubis, which just means pubic bone edema, really holds true, because that's what you see radiographically. You can't really get the precise imaging to understand the actual mechanism of the injury. And so a lot of people are put on crutches for 6 weeks. They feel fine on crutches, and they come off the crutches and try to play soccer again, and the pain comes right back. And that's something that we just see over and over and over again with our patients. And I think one of the main issues is just getting good imaging, and it's not easy to do. Like I said, the protocol's been out there for about 12 years, but unless you do it a lot, it's very difficult to get good pictures. And so this is a great example. What you see here is the pubic bone. This is the right and left pubic body. You got the symphysis with the normal cleft of fluid. And then, as you can see where the injury is, this fluid is seeping out into a separation between the fibrocartilage, which is all this dark stuff surrounding the pubic bone. And you can see it's just lifted off, and there's fluid intervening between the fibrocartilage and the bone. And so this patient had, pretty severe right and left-sided pain that correlated nicely with this injury. And you can see they also have a nice pectineus strain and some associated edema within the pubic bone itself. And this is another pretty common finding. And again, it's concerning for a stress fracture or something like that. But really what's happening is the fluid that seeps in between the fibrocartilage and the bone, just with repeated, pounding, gets forced across the cortex of the bone and into the marrow. And so that marrow signal actually gets pretty bright. And we see that in long distance runners in particular. They tough it out through the pain, and it looks like their pubic bone is made out of the same substance as their bladder. And so this is just a great MRI demonstrating the injury. And so this is a little diagram trying to show you functionally what we're looking at. You got some degree of muscle tear in the adductors and rectus abdominis, creates that imbalance. The fibrocartilage starts to lift off from the bone, and then you just see fluid seep in. And all we can really see is the fluid seeping in. And so in all these MRIs that we will be looking at, we're looking at that fluid intervening between the fibrocartilage plate and the bone, understanding that there is a muscular injury at that attachment site as well. We just can't see it that well on the MRI. Okay, I'm going to bring up this thing. Any questions? Everybody's doing okay? All right. Eric's laughing.
I saw Eric's laugh.
One other thing I want to talk about is, so like I said, Dr. Myers did some pretty interesting experiments that were ridiculously simple. But some of the other stuff he did was certainly still very simple, but also quite interesting. Once he understood that there was a lot of force being applied to the actual pelvis and its orientation was being influenced by these muscles, he then started looking at what other measurable changes took place in the bony orientation based on changing the core muscles. And so, for example, he put pressure transducers within the hip joint, and at this time it was a needle connected to a column of water. And basically he was able to show pretty dramatic changes of pressure within the hip joint itself as he tightened or loosened the rectus abdominis and adductors. And that's very important because there's a huge interaction between the hip joint itself, which I mentioned I don't touch on much in this talk, but it's incredibly important, and certainly femoroacetabular impingement is incredibly important in terms of causes of low back and groin pain. And so if you have impingement inside the hip joint, that's actually influenced by the surrounding musculature. And for example, if you cut the rectus abdominis in the cadaver and have a pressure transducer in the hip, when you lose that anterior pelvic tilt from the rectus abdominis, it actually exacerbates the impingement within the hip joint. And this is just a diagram trying to demonstrate that. Again, the adductors are a principal protector of the hip, and so the adductors can actually be the limiting factor in terms of how far you can abduct. And if you lose that protection from the adductor muscles not allowing your leg to go out from the midline, well, that extra degree of freedom in terms of range of motion from the adductors will then exacerbate the impingement in the anterolateral aspect of the hip joint itself, and then can exacerbate the damage to your labrum and subsequent hip pathology. And so we see a huge interaction with this. If you pick up a muscular injury, it can exacerbate the hip. In addition, you have a symptomatic hip pathology that subsequently results in changes within the core musculature, which can then predispose them to injury. And so we see in our practice 15 to 20% of patients have both symptomatic hip pathology and muscular injuries that need to be treated. And so we've really gotten very busy and are studying our increasingly large experience with treating these hip and muscle injuries simultaneously. The next couple slides are from our colleagues in radiology who we work very closely with. And this one is just showing you kind of the progression of these injuries. So this is basically a normal pubic bone and its muscular attachment. So you can kind of compare it to that example I had up earlier, where you see this is the dense fibrocartilage surrounding the pubic bone. This is pubic bodies. This is a T2 image, so fluid shows up as white. And you can see the fat fluid has been suppressed. And then basically, this shows a midline injury, and I'll go through the terminology in a minute, but it is important to note that these injuries don't always start at the midline, and very often they start laterally. If you are trying a pubic symphyseal injection for that concept of osteitis pubis or athletic pubalgia, this is a patient who will feel better from that symphyseal injection because you can see that the fluid is contiguous with the symphyseal cleft. So this patient will feel better, whereas someone who has an injury that's not confluent with the symphyseal space, they'll get no response. And that really predicts why that works sometimes, but not all the time. But for this example, you see a midline injury that then progresses to involve the left side. And if continued, you can see that this plate detachment will continue to progress laterally. And that's what we see here. You can also get an idea that the pubic bone itself is getting kind of increased marrow signal as that fluid is being pounded into the marrow itself along with the injury. Here we see that the injury is now progressing to the right side, and that gap is kind of widening. So as this fibrocartilage is just kind of retracting farther and farther down along with the adductors. Now you see the gap is pretty wide on both sides, and I think you can tell where this is heading. And so now on the left side, you got complete avulsion of those adductors, and based on this cut, you can't see it, but the rectus abdominis is probably also off as well since it's a common attachment, and that's what we tend to see. And then finally here you see a wide gap, and this is a complete avulsion on the left side and working on it towards it on the right side as well. And so just very briefly, I'll go through a little bit of the terminology that we use. We like to differentiate a midline detachment from the lateral, so left and right sides. Again, partially because the symphyseal injections that are tried elsewhere, it helps you understand why they work sometimes, but not all the time. And it also gives us a certain understanding of the treatment, because certainly these midline injuries really involve the muscles on both sides, whereas if you have a true isolated right side injury versus midline, it's a different treatment surgically. And there's the left side. And so we refer to it, oftentimes we just kind of talk about that fibrocartilage baseball cover, but in a lot of the literature that we've published, we refer to it as a plate. And that, again, is the same thing as the baseball cover. And it's just this really dense fibrocartilage on top of the pubic bone. And so we'll talk about plate injuries as well, and that's just that separation, that same mechanism. So just a few words about the treatment. Certainly, we diagnose a lot of injuries, and I've showed you just kind of the main central injury that can take place with these injuries. But certainly, there's a whole constellation of injuries involving all the components of the core, and especially the core musculature. And there's really specific patterns that we see. And so certainly, at the end of the talk, I'm going to go through a lot of different case examples, and that's just gives me an opportunity to talk about some of the more common patterns that we see. But certainly, we diagnose a lot of injuries, and not all of them are surgical. And for example, distal injuries not involving the pubic bone attachment tend to heal on their own with non-operative management, I should say. A lot of times they need a lot of intervention, but they just have to be non-operative intervention. So for example, this is a very severe adductor injury where you've got actual muscular avulsion, but it's between muscle belly as opposed to its attachment either to the femur or the pubic bone. And these tend to do well. I mean, they do amazingly well. So typically what we'll do is either ourselves or our radiology colleagues under ultrasound guidance will aspirate the interval hematoma between the muscle and inject some corticosteroid to help decrease the inflammation. And if you can just get these pieces of muscle within the same room, they'll find a way to heal together. And you get tremendous scarring associated with it, which may predispose that person to future injury. But certainly we will have a patient will aspirate a hematoma like this, inject it with some corticosteroid, and get them back out, and on a very accelerated rehab schedule to get back to full play. And they do really well. It's usually a couple weeks before they're feeling good, but they're able to get back and tolerate a lot pretty quickly. And that stands in pretty stark contrast to these central injuries that I kind of described to you already. And so one thing that we do often is manage the pubic bone plate injuries non-operative as well, and that's simply because there's a lot of incentive among many athletes to continue to play. If you're in a contract year or a professional athlete, or you have a scholarship to play, you have a lot of motivation, and also most people just don't want to stop. So it comes up pretty frequently that we will use various measures to temporize these injuries to help them get through some set, either a season or a tryout or something like that. And we actually did study this recently. So we took 19 D1 and pro athletes that we saw consecutively in a couple months. And these were athletes that we injected with corticosteroid at the site of injury, which is at that fibrocartilage plate of the pubic bone, in order to try to help them to get through the season. So we have a performance score that we use for all of our patients, and it's basically 1 through 5, just asking, basically a self-assessment of how they're doing. And so a 5 is that they have no pain and no limitation whatsoever. A 4 is that they're able to play, and they may have some symptoms, but it's not limiting them at all. 3 is that they have some symptoms. 2 is that they're no better than prior to the intervention, and 1 is that they're worse than prior to the intervention. So we really call a 4 or a 5 a success. There are people who have given us a score of 3 who have returned to play, but they're not doing everything that they were doing prior to their injury, and so we really don't call that a success. And obviously 1s and 2s, where they're either no better or worse, is certainly not something that we would call a success. And so for these 19 athletes in this study, we had a post-injection performance score. So a couple of days after we injected them, we asked them, how are you feeling? So this was 3 days after, and they gave us a score. And it was 3.9 was the mean score. So that's to say most of them, on average, the average patient after this was able to kind of return to play and still felt something, but wasn't limited by that. And we had 80% of the patients complete their season. This is a difficult thing to study. And 4 of the patients had something go on where either they had a contract negotiation issue, or they were suspended from their team, or got kicked off the team for various reasons. And so we don't know really what happens with those. So we obviously they didn't complete their season, so that doesn't count. But we'd like to think that maybe there was something going on there other than their injury. However, it's a complicated thing. It may be their injury. Interesting things that we found out was their performance score was higher when athletes were injected earlier in the season versus later. And that's really, in my opinion, I thought that was counterintuitive. I would have expected if you had, if you can make it through most of the season and then you have this little injury that's bothering you, but you kind of made it through for a while, and then you finally cave and get it injected before the playoffs, I'd think they'd do better. But it's actually people who had the injury injected earlier on did better. And I think that has to do with the amount of inflammation that builds up during the course of a season in any sport. And these injuries tend to get cumulatively worse. And so by the time you inject it, when it's really inflamed, it's just harder to treat with an injection. And then, of course, the big question that most people ask is, if I wait until the end of the season, is there any difference in terms of when I do get this eventually repaired, am I hurting myself in terms of my post-operative success? And so here, when we've looked at our data retrospectively in terms of maintaining our database and all of our patients, we see about a 95, 96% success rate in terms of getting a performance score or 4 or 5, 6 weeks after repairing these injuries. That's to say, 6 weeks after repairing these muscular injuries, 95% of people are back to their pre-injury level of performance. They still may have some degree of pain, but their performance is there. So when we looked at this in this relatively small group, we saw 85% of the patients reported at 6 months, which is also a longer time frame, a 4 or a 5 on their performance score. So that is to say, in terms of at least at 6 months, we've seen no statistical difference between the outcomes in these patients if they wait till the end of the season versus all comers. And then just a few words about surgical management, and I could really go on a long time about this, but I'll try to keep it short. But this is really, my passion and what I do every day. Really enjoy it, and probably the reason it's been a difficult thing for a lot of people to treat has to do with just really not understanding the pathophysiology of these injuries, which we've already gone through. And then also just the impulse to kind of treat all these injuries as the same. And certainly when we talk about the fibrocartilage plate injury, there is that commonality between all these injuries. But there's an incredible diverse series of patterns of injury that take place. And so it's just incredibly important if we're doing surgical to really identify all the structures involved. So what do I mean by that? I mean, that is to talk about the 15 to 20% of our patients who have hip involvement, whereas if you only treat the muscle injury and you're not aware of the hip problem, they may not have the response you'd expect. And in addition, we certainly see a tremendous interaction between all the different muscles of the core, so that is to say the rectus abdominis, the adductors, rectus femoris, psoas, obturator, internus, and externus, and failing to recognize these injuries and treat them accordingly will also likely give you unexpectedly poor results. But basically the concept is from the central injury, when you're talking about the rectus abdominis and adductors, it's just to broaden and strengthen the attachment to the pubic bone. And what you're doing there is just repairing the muscular injury, and then the fibrocartilage itself is stabilized and restores balance.